The diagnosis of subclinical neovascular AMD with OCT angiography. Dr. RAMAKUMAR from Madhya Pradesh Ophthalmological Society, State Ophthalmology.
Good afternoon, session officials and my colleagues. I'm going to present on diagnosis and follow-up of subclinical neovascular age-related macular degeneration with OCT angiography. There is no financial interest. So the Conan study group has defined the subclinical neovascular AMD. Though AMD is defined as a condition, patients beyond 50 years of age in which structure and function of the macula deteriorates. In that, non-exudative MNV, that is macular neovascularization, it has been recognized, and it could be identified more commonly with advances in imaging technology. But previously it was named as quiescent CNVM. So the Conan study group, which has recently published AMD nomenclature, they didn't agree with that word quiescent. So all those cases of neovascularization, sub-RPE neovascularization without signs of activity, clinical activity like exudation, that is fluid, either retinal or subretinal, and subretinal hyperrefractive material or hemorrhage. Any of these things, if they are not there, then it is called as subclinical neovascular AMD. So there are certain, like after the advent of imaging modalities like OCT angiography, ICG angiography, and recent other things, there are certain publications regarding this, and in this publication they found that by 12 months the risk of exudation was greater for eyes with documented subclinical MNV compared with eyes without detectable MNV. So they could see progression in certain cases with subclinical MNV at 12 months age, at 12 months follow-up in this study. So the other study found that out of 34 fellow eyes of frank AMD cases, they could find subclinical MNV in 5 cases, and in that only one patient developed clinical neovascularization. They tried to look at the subclinical characteristics of the subclinical neovascularization, and they tried to see if there are any specific characteristics which can predict the conversion to clinical neovascularization in the follow-up period, but they could not find any such this thing, and they also mentioned that treatment is not required for these subclinical CNVMs. So my abstract regarding my study is a observational prospective study. I just followed up the patients where clinically, when I examined and found that there is a subclinical CNVM, I followed them up at least for a period of 6 months, and then I'm trying to present my results. So I'm directly presenting the cases here. So there was a 54-year-old female who came for a routine checkup. BCVA was 6, and 6. There was an RPED near the fovea in the right eye, which prompted me for OCT and OCT angiography. If you can see here, there is an RPED in the right eye, and when I did the OCT angiography, you could see the flow signal in the B scan, and also a subretinal sub-RPE neovascularization on the outer retinal slab. So this patient was followed up for almost more than a year, and you can see this I kept as a reference, the other eye outer retinal slab for a reference. So though there is little change in the shape of the vasculature has little grown, there is no clinical evidence of activity in this case. And there is a second patient who was a 60-year-old male. His 65-year-old brother was treated by me only for peripapillary CNVM, and the 85-year-old mother was also treated for neovascular AMD, frank neovascular AMD, and BCVA 6, and 6, and there was a subfoveal RPED, and which prompted me for OCT angiography. You can see the flow signal in the B scan, and also a neovascularization in the outer retinal slab. This also was followed up for almost 6 months, and then there was no growth in the neovascularization. And third case was a 74-year-old male who was diagnosed as frank AMD, wet AMD in the right eye, and when the other eye octa was done, there was a subclinical neovascular AMD. So this was also followed up, and this patient, you can see there is a frank wet AMD in the right eye, but there is a subfoveal RPED which did show that CNVM in the outer retinal slab, and also a flow signal in the B scan. So this is the patient who has longest follow-up in my this is the right eye showing the neovascularization. So this is the patient having the longest follow-up. You can see August 2021 to April 2023, more than 1.5 years. If you can see towards the disc, there is a growth of the CNVM, but there is no clinical activity of the CNVM. So I'll show you this. So if you can, I tried to focus on that area where there was a growth towards the disc, and here also the flow signal was there in the B scan, but there is no clinical activity on OCT. So this is the fourth patient. Left eye 6/9 vision was there, and when I did the OCT angiography, there is a atrophic area also in the area of the RPED. So the vision was little less, but though there was no clinical activity, no exudation, no subretinal hyperrefractive material. So this patient also showed neovascularization in the outer retinal slab, and during follow-up, this is also almost more than almost an year follow-up, and there is no change in the neovascularization and no clinical activity. And this fifth and sixth patients, there was MNV, but I could not get the follow-up octa, though I could see them at the end of 6 months and 8 month follow-up. There was no drop in vision. Both of them were maintaining 6/6 vision. So this was the outer retinal slab, this thing. So for a reference, I have made another patient who had a frank AMD in the other eye, and this eye showing a subfoveal RPED, but there is no neovascularization. So I conclude by saying that there is no need to hurry to treat subclinical AMD till the time we get more prospective studies with sufficient numbers, with widespread use of octa and other advanced imaging investigation modalities. Thank you.
Just did you measure the thickness of the choroid?
Pardon?
Because did you measure the thickness
I
of the
didn't
choroid?
classify into the pachychoroid and the AMD different things. I just looked at the neovascularization.
Because most of them had a thicker
Pachychoroid.
choroid compared to
Yeah. There is another paper which has published the neovascularization associated with the pachychoroid and the neovascularization associated with AMD. But like in these cases, one patient had a family history of AMD and the other patient had other eye AMD. So difficult to say whether to name it as a pachychoroid related neovascularization or AMD itself. All are fitting into that more than 60 years of age.
I have a question.
Yes.
You have shown the patient is 6/6 and he's having subclinical neovascularization.
Yeah.
And clinically there are no signs. But if the patient is having symptoms like metamorphopsia, then would you inject or?
No, without a
If the patient is
evidence of
symptomatic.
without an evidence of clinical, because as I mentioned, the diagnosis of activity is given by either a presence of fluid, either retinal or subretinal, or hemorrhage, or subretinal hyperreflective material beyond, like in front of the RPE. So if anything of these things are not there, and if just the because we do see serous RPDs giving metamorphopsia also, and we are not treating them. Just like that, we are not treating them.
You wouldn't
As on today, the recommendation is that not to treat, because in all the diseases we are going for early detection, like glaucoma also, pre-glaucoma, all these things. So they go for some kind of precautions or preventive treatments in those cases. But here, because there is cost involved and there is lot of issues with the patient coming for the treatments, there is no need for hurrying up for the treatment in these cases. That is what I wanted to put forth by showing these cases.
And what are the specific things where you include them as subclinical neovascularizations? What are the criteria where you have
that's what I mentioned. It may be a routine clinical examination which is showing a RPED, or wherever you are doing a OCT. If you are finding an RPED, do an octa and see if there is a neovascularization. But no clinical activity. Clinical activity defined by fluid, either retinal or subretinal or subretinal hyperreflective material. We call it as SHREM, and hemorrhage. If these three are not there, then it is subclinical.
I think
Have you done ICG in any of these patients?
No, I don't have an access for ICG.
ICG. And what
Previously, when they started giving a diagnosis of subclinical AMD, they started with ICGA. But nowadays, all the recent papers which are published are based on OCT angiography.
And what would be the follow-up protocol do you follow for these patients whom we are not treating?
I'm taking it as 6 monthly follow-up.
6 months.
I'm advising the patients who had pathology in the other eye, they are coming anyway for the regular follow-ups. Like one patient has been getting treatment for wet AMD in the other eye. So he's coming for a frequent follow-ups, but otherwise without anything in the other eye and only for this eye, if I have to call, tentatively, there is no recommendation for this as such. Tentatively, I have taken it as 6 months.
As it was rightly mentioned, like it could be a part of the pachychoroid spectrum itself. Like if you follow it up and if the choroid is thickened and if you have an ICG, on that if you see a hotspot in the later phases, probably treating, is vision the only criteria we are looking at?
Pardon?
Is vision the only criteria we are looking at? Because vision has never dropped.
Yeah, vision has never dropped.
Never
I'm
dropped.
looking at the activity, clinical activity on the OCT also, no? All the B scans I have tried.
Sometimes the OCT won't show anything.
That's what I'm saying. See, I showed one of the cases, there is a growth in the neovascular membrane.
Right.
But still there was no clinical activity. So my proposition is that till the time you don't see the clinical activity, because not to increase the treatment burden on the patient, cost-wise also and for the treatment purpose also, not to increase the treatment burden, I propose to say that whatever that has been worldwide has been proposed, not to treat subclinical cases. Till the time they become frank clinical cases.
Thank you. I think we have exceeded time. We should stop.
Yeah.